Good afternoon, all.
Good afternoon.
I see.
Good afternoon.
Good
Yes.
afternoon.
Yes, good afternoon. So, thank you for joining us today for our session, which is intended to focus on the IPC targeting Marburg virus disease. It is the current outbreak we have in Rwanda. So today we are going to have an interesting and interactive session where we have some visitors who are supporting our country in terms of reference, in terms of response to the Marburg virus. So me, I'm Dr. Jean-Jacques Rakiza. So, I'm here as a facilitator of this session. We have Dr. Marie-Claire as the presenter in our session today. And I can start from the Infection Prevention and Control Rwanda organization team to introduce themselves. Then our members who are joining this session today, they can follow by introducing themselves. Then we let our visitors to introduce themselves after everybody has been introduced. Let's start with Dr. Tarisis Mpunga. Can you introduce it to our team so that we can know each other? Thank you.
Good afternoon to everyone.
Yes, good afternoon.
It's good to see you again. Tarsis Munga, Lilisi Ashika, member of IPC organization.
Okay, thank you.
Thank you.
Dr. Marie-Claire, over to you.
Good afternoon, everyone. Dr. Marie-Claire Ndaisava. I'm a member of IPC Rwanda organization, and I work at Sehashika. Thank you.
You are welcome. Marie-José, can you introduce it to our team?
Thank you. My name is Marie-José Mukagendaneza. I'm in charge of infection control at Sehashika, Rwanda.
Okay, thank you. So, Vensa, can you introduce it to the team?
Good afternoon.
Yes, good
I'm called
afternoon.
Vensa Hatangindowazi. I'm working at Sehashika.
Okay,
Thank you.
Thank you. Francois Dusengimana.
Hello, I'm
Hello.
Francois Dusengumuremyi, IPC member, Nembadi Street Hospital.
Okay, you are welcome.
Hello?
Yes, you are welcome. Diane Muchiza, can you introduce to the participants for today, if you are hearing from us? Diane? Okay, let's go to the Valence. Valence, do you hear me?
Good afternoon.
Yes, good afternoon.
My name is Paris Lee. I'm working at the Moses Hospital.
Okay, thank you. Niyibikora, can you introduce yourself?
Hello, everyone.
Yes, hello.
Niyibikora Marie Jose. I'm YPC nurse at CHUB. Thank
Okay.
you.
So CHUB is a French abbreviation. It means Centre Hospitalier Universitaire d'Outare. So it's a teaching hospital in the South
Yes,
Province.
sir.
Okay.
Yes,
So,
sir. Thank you.
Dr. Amber, do you hear me?
Yes, I can hear you. Can you hear me?
Okay. So, maybe you have, this is the first time you join our session. So our team has been introduced to you. So maybe can you introduce to our team and welcome some if you have any word to tell our team. So over to you, Dr. Amber.
Thank you. Yeah, I'm really happy to join. My name is Amber Vasquez. I am an infectious disease doctor, and I work at the U.S. Centers for Disease Control and Prevention in Atlanta. I work in healthcare, infection prevention and control. So I work in a global area of CDC where my group spends a lot of time traveling overseas to countries with limited resources to try to improve their healthcare safety, to try to prevent healthcare associated infections, strengthen their IPC programs, and so on. I'm here now because I am helping to support the Ministry of Health and our local CDC country office with the IPC healthcare aspects of the Marburg response. Thanks. Back over to you, Jacques.
Okay, thank you so much. So as everybody has been introduced, others, they are continually coming. So keep introducing through our chats. So now let's welcome Dr. Marie-Claire. Can you share your screen and present the session? Okay.
Good afternoon again.
Yes, good afternoon.
So we are going to discuss infection prevention and control in case of Marburg virus diseases. This is a presentation we did last 2 weeks, but many people has requested the presentation to be repeated for assimilation of different concepts, but also for discussion about different practices that are done in our hospitals to try to limit the outbreak, but also to stay vigilant so that we can not miss subsequent cases. So when we did, this is the outline, and most of the information that we are going to discuss are retrieved from WHO recommendation from the guideline that has been released last year for management and IPC in case of Ebola and Marburg disease. So when we talk about Ebola or viral hemorrhagic disease or Marburg, Ebola and Marburg are viruses that belong to Filoviridae family. They both cause hemorrhagic fever, which can lead to extensive bleeding, multi-organ failure, and in most of the situation, they cause death. The case fatality rate is between 24 to 90, with average of 50. The incubation period is from 2nd to 21 days after being exposed to the virus. And in case of controlling these diseases, which still now they don't have treatment and vaccine are under investigation, we have to apply infection prevention and control to limit the outbreak and do empirical management, as well as use those drugs and vaccines that are still under trial. Therefore, each healthcare professional must be able to apply infection prevention control measures appropriately so that they can serve for the better of everyone. Therefore, the objective of this presentation is to provide clarity on key IPC recommendations as they pertain to settings that pose different risks in healthcare workers, including activity like screening, triage, and providing care of suspect or positive case for Ebola and Marburg virus. So when we talk about the transmission, where can we get the virus so that outbreak is declared? We have two modes of transmission. Normally, the virus resides in different animals like African bats, and the transmission can happen as a primary transmission or a secondary transmission. Between those reservoirs of viruses like African bats, they can transmit the virus between themselves, but to transmit the virus among women, among people, it can happen as primary transmission when a human is in contact with the feces or the meats from those bats, or when the person is in contact with non-human primates. For example, for the people who eat like monkey meats, they can get infected. And the second transmission is between human to human, which can happen by direct contact of the body fluids or from the person who is infected, or infected from indirect contact when the person come into contact with equipment or hands that are contaminated by the virus. When we talk about the transmission, a spillover from animal is that we defined as primary. Transmission is commonly rare, but when it has happened, it can lead to outbreak and lead to more human-to-human transmission. And this primary transmission is also called zoonotic or animal-human transmission. So in secondary transmission, as I have mentioned, which is the most common way of spread of the disease among humans, I say that it can be direct contact transmission or indirect. When direct, it means that we come in contact with infected body fluid, and indirect, we come in contact with contaminated item, which play as the intermediate to or medium to transfer the virus from the infected person to the susceptible host. Healthcare workers who provide care are the most high-risk people for getting infected once the outbreak or the first case has been identified. The transmission also can happen by sexual transmission, as it has been documented among the people who suffered from Ebola. Ebola virus can survive in semen until 12 months. Therefore, those people who are discharged from treatment center, they must apply different measures, protection, use a condom, for example, or no sex after the recovery until they are declared negative on PCR of the semen. So blood is the most infectious body fluid because it contains too many viruses, what we call high viral load. And high viral load is seen in people with acute illness and people who have already entered into the late phase of the disease. And those people are the one also showing exhibition of many body fluid, hemorrhage from different parts of the organ, like the nose, the mouth. And then there are those people who require intensive care. And at this time, it is where the viral load is high and too much of body fluid are coming from those infected people. And again, higher viral load is seen in diseased body. Therefore, we have to be careful when we are taking care of the disease. Specifically, the positive confirmed case or the probable cases when we don't have laboratory confirmation. We can have transmission also through other body fluid like breast milk, saliva, sputum, stool, urine, and vomit. There are no published epidemiology or lab study that suggests airborne transmission. However, when we are doing those aerosol generating procedures, we must apply airborne transmission precaution. When we have to use N95 mask, and then we have to protect the mucus by putting on goggles or face shield. We are going to see in the detail after. When we talk about high risk exposure, we mean when the person can be infected once in contact with a potential or a positive case. For example, when the body fluid is in contact with non-intact skin, for example, when someone is having small wounds on the hands and then they are taking care of positive cases, it is easier to get infected. And mucous membrane, they are very soft, and then they can allow the virus to enter easily into the body. Another high risk procedure is, or another high risk exposure is needle stick or sharp injury with contaminated equipment. And we have the last one, cross contact during late stage of the disease and during funerals, because here we have seen that the person is having high viral load, but also it is the time they are excreting too much of body fluid. As we mentioned, sexual transmission, in case of Marburg, it can stay in the semen up to 284 days, which means around 9 months. That's why we need education and protection from the community, specifically for the people who have been discharged from the treatment center. Mother-to-child transmission can also happen during delivery and breastfeeding. That's why after after treatment, the mother who is breastfeeding can either stop breastfeeding so that they cannot transmit the disease to the baby, but also during the monitoring, the post-recovery monitoring, they do also PCR for the breast milk until they declare as PCR negative. Therefore, appropriate IPC precaution must be in place to reduce the risk of transmission from one person to another. So when we talk about the transmission, we have to know when the person is able to transmit the disease. As we have said that the incubation period is from 2nd day to 21 days, but the person who can transmit the disease is the person who have started showing the symptoms. An asymptomatic person cannot transmit the disease, which gives a window to do the screening and the triage of our cases. If we capture the person as early as possible, we can be able to control the outbreak. So the communicability period is the time when the person continue to be able to transmit the disease, which means from the time the infected person starts showing the symptoms until the time the person is declared negative. So that period where the person is still having the virus and is having symptoms is the one we define as communicability period. And this period ends after the patient has fully recovered together with negative PCR test. So now what is the case definition, or what are the symptoms that we are anticipating to see in infected people? So here we have the person who is infected, and then we have a visitor or healthcare professional who is coming to take care. So this may be considered as a day one where this person who is taking care of this one lying down is in contact with the virus if they have not applied appropriate infection prevention control measures. Once they are in contact with the virus, it can take 2 days. From second day, we can anticipate or we can expect the person to may have symptoms, but we have to follow this person until 21 days to make sure that we do not miss any day to notice the symptom. So this person may feel well and at this time is not going to transmit the disease. It means that the virus is either being multiplying in the body before it is expressed outside as fever, common like fatigue, headache, joint pain, muscle pain, back pain, and sore throat. These are the first signs that we see in people who have been infected, and at this time they can be contagious. They can transmit the virus to another person. And as you see, these are the symptoms we see in case of malaria or other infection like flu, which is also a viral infection. And in our settings, it may be, these symptoms may mislead the clinician if they are not vigilant. In this situation, we have to be careful and then do not say it is just malaria and then we cross our hands. Even if the malaria test is positive, we still need to test for Marburg because we are in the outbreak period. As the person continue to not be treated or as the disease progresses, the symptoms start to aggravate and we come from this dry period where we don't have too much of body fluid coming out to a what we call wet period where we have diarrhea, nausea, vomiting, bleeding, hiccup, and redness. At this time, the person is highly contagious because is giving out too much of body fluid, but also the viral load here is continuously increasing. And then we reach the last phase where the person now has suffered multi-organ failure, and this person, in most of the situation, it is not easy to save. And these people, they die by either bleeding profusely, liver and renal failure. But we are lucky in our situation. The people who have reached this last phase, some of them have recovered, which is also a congratulation to the healthcare professionals who were taking care of them. So now we can see, the duration of the period of isolation. Immediately you understand it is the time you suspect the person, and then the day they start having the symptoms, they must, as they are contagious, they must be isolated until the day they test negative. The person can be discharged after treatment after having 2 negative. For example, there is the reduced of symptoms. If fever is no more there or significant symptoms have subsided, and then with a negative PCR test on day 3 or later following the resolution of symptoms. These are the protocol they are following for discharging positive cases from isolation. They must be recovered from the symptom they were having, but also PCR test negative. If the person is still having symptoms, we must have 2 negative PCR tests we've taken between 48 hours apart. Otherwise, we must have also significant improvement in a clinical condition, but also the person must be able to be independent in doing the routine activity as before. So these criteria must be observed before discharging the person from the treatment center.